still 25 to 30 gray. If you wait a year, you have about, for the skin, nearly 50% recovery. So you can add up 50%. So you arrive in between 30 and 37.5 gray. So that way you can individually per organ and for the interval estimate the residual dose. And if you add up then the total doses, you're much higher than if you would give everything in one time.
Okay, thanks a lot.
Thanks, Professor Portman. We are running out of time, and I think we don't have no more questions. Now I'm going to proceed to the next speaker.
Okay. And now we move to our next speaker, Professor Joseph Lukrow, and very, very interesting subject. What about systemic management of leptomeningeal metastasis? Please.
Thank you very much. It's always a pleasure to be with you. I will just share my screen now. I hope that you can see it.
Okay, yes.
Yes.
Okay. And you asked me this challenging question about the systemic management of leptomeningeal metastasis in breast cancer. And I could make it very short and saying no, there is no new solution. However, I will just try to go through several things that we know, and just to remind you that there was a very important and a good update in 2017 by collaboration of ESMO and also the NO association, that they are just giving some guidelines for the clinical practice and treatment, diagnosis, and follow-up of patients with leptomeningeal metastases. So what I want to remind you is that the breast cancer, lung cancer, and melanoma are the most common causes of leptomeningeal metastasis. They are mainly in the context of progressive systemic disease, sometimes as a first metastatic evolution, and rarely de novo at the time of initial diagnosis of the disease. If we focus now at the epidemiology and we look at the different things we know in general, here you have the recommendation, and you will see during my presentation that the level of recommendation and the grade are very low because we don't have any clear prospective data or even devoted, I would say, trials addressing the question of taking care of leptomeningeal metastasis. But we have some retrospective analysis that will help to know that first, it is associated with brain metastasis between 1/3 and half of the cases, but main risk factors for having leptomeningeal metastasis are when you have some brain metastasis is opening the ventricular system during brain mets surgery or resection of cerebral mets. Higher when brain surgery was followed by stereotactic radiosurgery than radiosurgery alone. And so you see that the part of the surgery of the brain might be important as one of the factors that will spread the disease from the brain to the leptomeningeal space. And concerning the breast cancer, lobular and triple negative subtypes were more frequent situation according to the general frequency of these types of cancer. So the absolute number are more frequent when you look at the ductal, potentially even HER2, but regarding the low incidence of lobular breast cancer, the proportion is pretty elevated when you look at the proportion of patients with breast cancer and leptomeningeal metastasis. So the other thing that I want just to remind you are the prognostic parameters, prognostic factors that we know. First of all, the general prognosis of leptomeningeal metastasis of breast cancer are very, very bad, between 6 and 8 weeks historically if you do not treat it. And when you treat the patient, between 6 and 26 weeks if you look at the different publication. The 1-year survival rate is between 16% and 24%. And this could explain that not only brain metastasis, but particularly leptomeningeal metastasis are clearly since nowadays an exclusion criteria of patients with brain mets and even with dedicated trial to brain mets population. The factors that are influencing the overall survival when you take care of this patient is one, the performance status, two, the protein levels on the cerebrospinal fluids, and particularly the pressure that you might have on the cerebrospinal fluids, three, the administration of combined modality treatments that, if you can do it, will probably increase the outcome and improve the overall survival, and the initial treatment effect, which is clearly one of the main prognostic parameters. If you don't have effect, then the prognosis is awful for in a few weeks. So just to remind you, one very important thing is that the symptoms might be in part or largely related to increased intracranial pressure due to the cerebrospinal fluid circulation disturbance, and that they can be rapidly alleviated by lowering intracranial pressure through CSF drainage. That means that even if you have some very important symptoms, sometimes local, not only treatment, but just trying to decrease the pressure on the CSF might help to better control the symptoms. And one other very important thing is, if you want to just assess the situation and follow and try to have objective responses regarding the symptoms, it's very important to have detailed neurological examination at the beginning of the leptomeningeal metastasis process. So what to do for the diagnosis? Just to remind you that we have two important approaches. The gold standard, of course, is CSF cytology, and if it's positive with presence of tumor cells, this is the absolute sign, of course, of leptomeningeal metastasis. However, the neuroimaging is important, and you see that the MRI is a big part of not the solution, but of the contribution to the diagnosis, particularly if you have equivocal or negative CSF cytology. And the typical MRI findings are of linear leptomeningeal metastasis, called the type A, or nodular leptomeningeal disease, called the type B. And you can find this on the free access of Annals of Oncology guidelines and ESMO guidelines. And you can see that this kind of process is very important because it helps to build diagnostic criteria even for potential future trials that we might have. So the diagnostic criteria are this one. We have type 1, that means that always in type 1 it's a positive CSF cytology or eventually biology, with 1A the linear type on MRI, 1B the nodular, 1C it's the mixed linear and nodular, and the normal MRI it's 1D. And the type 2 criteria for leptomeningeal metastasis are when the cytology is negative or equivocal, according then to A, to B, to C, to D, respectively, the MRI finding, as you can see here. This is the way we classify now the leptomeningeal disease, and the recommendation, if you follow the ESMO guidelines, is to have a diagnostic workshop that includes cerebrospinal MRI, brain MRI, but also CSF flow study that might be repeated in some patients if you don't have the clear diagnosis and if it's important to have it. Two considerations regarding the treatment. One, the pharmacotherapy and the general consideration. The first thing is that there is a priori no reason to believe that systemic pharmacotherapy for contrast-enhancing manifestation of leptomeningeal metastasis should be less efficient than for other systemic manifestation of cancers. And increased CSF protein levels in most leptomeningeal metastasis patients confirm probably that the blood CSF barrier is commonly disrupted. So all the history, what we build about this blood CSF barrier is potentially important at the beginning of the process, but not when you consider to use potentially systemic treatment. And this is a very important point. The second one is that in the absence of blood CSF barrier disturbance, The drug distribution into the CSF depends mainly on drug transports across the choroid plexus and not across the blood-brain barrier. So that means that when you investigate all these points, that's, let's say, pharmacological point of view, or ideally in a clinical research approach, you have to be very, very careful about the way you will build the strategy if you want just to have a pharmacological approach to try to understand the drug delivery and the impact. The common systemic treatments for breast cancer that we have are usually, I would say, the same. We don't have any specific trial that have addressed the question of the optimal systemic treatment choice for the leptomeningeal metastasis. A concordance of what is very important, more than 90% have been reported between the HER2 status of the primary tumor and the tumor cells in the CSF in some small reports that we have from different institutions. Occasional response of leptomeningeal metastases have been reported also with endocrine treatments in general. However, if you remember what I've said initially, the tumor are often resistant to endocrine therapy at the time of leptomeningeal diagnosis. And there is one historical point which is more, I would say, from the hematologist expertise and experience, is that the high-dose systemic chemotherapies, including high-dose methotrexate, cytarabine, or tiotepa, might achieve cytotoxic CSF concentration, but of course with major toxicity limitation in patients with advanced disease, and it's why usually we don't use this kind of approach with high-dose systemic chemotherapy to try to address a better control of leptomeningeal metastasis. What about the intra-CSF pharmacotherapy? First of all, there is no one trial that have demonstrated the overall survival benefit using this approach comparing to a systemic-only approach. It should not be administered to patients with symptomatic hydrocephalus who required shunt placement without on-off option, because then you have dissemination of the drug, systemic dissemination that might be more toxic. It's preferably through a subgaleal reservoir and intraventricular catheter. And there are 3 agents that are classically used, the same that we were using in high-dose chemotherapy approaches: methotrexate, cytarabine, liposomal or not, and tiotepa. These 3 drugs might be used directly by intra-CSF administration. When you look at the difference between methotrexate, cytarabine, and tiotepa, you have here the half-life in the CSF, the recommended schedules, and the prophylaxis of adverse events. Particularly, don't forget folinic acid rescue for the methotrexate, and oral steroid also for the liposomal cytarabine that you might use sometimes if you have the approval. Radiotherapy might be part of the treatment strategy. There is no randomized clinical trials to assess the efficacy and the tolerance, but usually it's focal radiotherapy when it's used in exceptional cases for Koda-Equina syndrome or cranial nerve palsies. And there is exceptional whole brain radiotherapy and NAVRAX in case of extensive nodular or symptomatic linear disease, but it's not usually what we are recommending. So do we have any new options? And this could be, unfortunately, very short. One, for the HER2 positive disease. There are some reports, some small series of intra-CSF trastuzumab that you can use. It's possible, but there is no demonstration of superiority of this approach compared to the systemic anti-HER2 treatment. We have, you know very well, some new data with trastuzumab deruxtecan, and particularly with tucatinib that was published in New England Journal of Medicine, focusing on the impact of tucatinib in combination with trastuzumab and capecitabine in patients with brain mets. However, what is very important, if you look carefully at the inclusion criteria, the patients with leptomeningeal disease were excluded from this trial. So we don't have any idea of the impact of these new approaches for patients with leptomeningeal disease. What about the triple negative disease? And again, we can go through several approaches, but I will just focus on what we have new that might be potentially interesting, the sacituzumab govitecan approach. And again, just to remind you that even if you look here at the response rate and the changes in tumor size that was published again in New England Journal of Medicine, all the patients with brain mets were excluded from the trial. So that means that we don't have any idea of the impact of this new approach with monoclonal antibody. This is sacituzumab govitecan, but we have exactly the same thing for the immunotherapy, even if it's actually probably less interesting in general in triple-negative disease that sacituzumab govitecan regarding the possibility of use it for all the triple-negative breast cancer. For hormone receptor positive disease, I will not go through all the things, but as I mentioned before, there are several reports reporting some impact of tamoxifen, of aromatase inhibitors for some patients, but some patients have been treated in the CDK4/6 inhibitors trials in metastatic situation with brain mets, and some of them potentially with leptomeningeal carcinomatosis. There is one report actually that was last year in the breast, showing efficacy in combination with letrozole and abemaciclib. But just to show you here that once for abemaciclib, you see that in general, some patients were excluded from the MONARCH 1, MONARCH 2, and MONARCH 3. But on the phase 2 trial, there are some patients with CNS metastasis here, and you see that we might have some small amount of response rate, about 5%, as you see here in CNS mets. And patient that was previously treated, you can see that they showed some potential decrease in the sum of their intracranial lesion in about 1/3 of the population. So it might be an interesting approach. We have also with ribociclib some data that you can see here. In the majority of the cases of the trials, the patient with CNS mets were excluded, but in MONALEESA 3, we have some patients that have been included, and we have some small data that are potentially confirming the role of CDK4/6 combination with endocrine treatment in patients with brain mets, and why not maybe with leptomeningeal metastasis. And for palbociclib, it's the same thing. So in the majority of the cases, the patient were excluded, but we have some particular reports. So at the end, what I will say is that I'm sorry to say that there is no any evidence about the optimal strategy. There is no specific trials due to the bad prognosis. There is a specific trial registry is needed to be initiated, and some different groups like the oncodisting group in Jules Bordet, when Ahmad Awada I would say the main person here, which is actually discussing and trying to build this strategy for a particular situation like the leptomeningeal metastasis. So there is a very important initiative here, and particularly this initiative need to be supported with the approach of the new treatment options that we have in HER2 positive, in triple negative, and in estrogen receptor positive disease. Thank you for your attention.
Thanks a lot, Professor. But I have one comment about do you recommend use intrathecal therapy, whatever is type, to all cases of TSF positive cases?
I will say that in general, we try to do it at the beginning. We have some difficulties and to continue, to be honest, yes. After several injections of intra-CSF chemotherapy. Usually we try to initiate this, particularly when the patient had some symptoms. Our feeling is not that we will have an increased rate of response, but maybe that we will have a quicker response and quicker and better, I will say, earlier control of the disease if it can be controlled. But my own experience shown that I have the experience that some patients have sometimes impressive response with the systemic treatments. I remember one of my patients who have more than 1.5 years complete control of leptomeningeal metastasis just with everolimus exemestane, and I give her this because I didn't know what to do, to be honest.
Yes.
So there is a lot of things to do. Usually, yes, we use intra-CSF at the beginning, but we quickly switch to systemic treatments.
Yes. And what about neurological prophylaxis? Do you use it?
No.
At all?
Prophylaxis for breast cancer, for leptomeningeal metastasis,
yes.
No, we don't use it.
Oh, thanks a lot.
Thanks, Professor Egaro, for this very nice and very informative presentation. Now we are running out of time, and you are going to move to next speaker.
I have the pleasure to introduce Professor Mehra Golshan, from an eminent surgeon from the States. He's a regular attendant of our conference, the BGICC. We used to see him, to meet him here in Cairo every year, but unfortunately this year we are going to see him only through the screen. He's going to give us a very interesting topic for all of us, the management of breast recurrence. Please, Professor Mehra.
Good afternoon, my dear colleagues and friends at BGICC 2021. I wish I was there in person to be with you. Inshallah, next year I'll be there in Cairo. I am so honored to be here with you virtually. Of course, my dearest friend, Professor Hashim Al-Ghazali, for putting together truly the preeminent conference in the Middle East and North Africa and around the world. I am super thrilled to be giving a few talks today, and I look forward to a really great discussion in the sessions to come. I'm going to share my screen and start the next talk, and this one is on the management of in-breast tumor recurrences. So I currently serve as the Deputy Chief Medical Officer for Surgical Services at Yale and the Director of the Breast Program and Professor of Surgery and Oncology at the Yale Cancer Center, Yale School of Medicine. You know, this harkens back to the days where we were traveling together and sitting together, and this is an evening in Cairo looking over the Nile, having a wonderful dinner with all my colleagues at BGICC. And again, God willing, when COVID passes, we'll be together next year in person. So when we talk about in-breast recurrences, I really think that we need to now start slowing down and thinking about various options for our patients. I want to go over a little bit on local recurrence, the regional recurrence, the management, and some kind of concluding statements. So local recurrence is a reappearance of the cancer or new primary on the ipsilateral chest wall of breast. Just basic definitions, right? Regional recurrence, tumor involving the regional lymph nodes, usually ipsilateral, axilla, or supraclav or infraclavicular and inframammary node, but usually ends up being the axilla. I think the management is very complex and layered, requires multidisciplinary assessment. And the treatment has the potential to provide long-term disease control for patients who really develop isolated local recurrence after breast conservation or mastectomy. I think there is a difference between the mastectomy patients and the breast conservation therapy. Usually there's earlier recurrence in the post-mastectomy radiation. The median has been 2 to 3 years as opposed to 3 to 5 years for breast conservation. Often on the mastectomy, it's on physical exam. More likely to involve in the mastectomy setting, regional lymph nodes, and more likely to have distant metastasis and poorer breast-specific survival. And breast conservation therapy recurrences can really be true recurrences or a second primary. The truer recurrences have a higher rate of metastatic disease and poorer prognosis as opposed to the longer-term second primary. There are multiple risk factors. The major risk factors are the number of positive axillary lymph nodes, the size of the primary tumor. Others are the patient age, the hormonal or receptors, and the HER2 status, presence of LVI, whether there was extracapsular extension, positive margins at the original surgery. Local recurrence after breast conservation with radiation therapy. So if there was no radiation and the patient underwent breast conservation, those local regional recurrence rates were fairly high. It's about 10 to 40%, but you could really consider this to be a standard of care for women over the age of 70 right now with estrogen-sensitive disease, early stage 1 or 2 breast cancer, is to do breast conservation without radiation therapy and the consideration of endocrine therapy. The usual treatment could be surgery and, if appropriate, adjuvant chemotherapy or neoadjuvant chemotherapy, hormonal therapy, or targeted therapy. Radiation should be considered if you're going to repeat breast conservation when radiation therapy was not given. If there is distant metastatic disease or local extensive recurrences or wound control problems, you could consider palliative mastectomy, but often if we could get systemic therapy to lower that burden of disease, that'll go a long way in helping local therapy. Looking at the elderly without previous radiation therapy, I think the CLGB trial from Kevin Hughes 9343 has really provided so much wealth of data. Looking at women over the age of 70, clinically no negative, lumpectomy to negative margins, tumor size under 2 centimeters, usually positive disease. Some did have axillary nodal surgery, others didn't, randomizing to radiation and tamoxifen or tamoxifen alone after breast conservation. We looked at in-breast tumor recurrence rates, and certainly, yes, the additional radiation therapy significantly reduced that, statistically significantly reduced that from 91 to 98%. However, the time to subsequent mastectomy really did not differ, and more importantly, there was also no difference in survival. So, yes, radiation will lower in-breast recurrences, but the ultimate risk of final mastectomy, second primary breast cancer, distant recurrences, or dying of breast cancer really remain the same. How about breast conservation with radiation therapy? A meta-analysis of 17 trials for women over age of 40 undergoing breast conservation therapy in the modern era. Local regional recurrence rates are very low, under 5%. Most patients, if possible, if they recur, should receive salvage surgery. And about 85, almost 90% of the time, these patients are operable. I think the standard is mastectomy. And if there is involvement of skin or inflammatory, then we really want to try to decrease that burden of disease with systemic therapy prior to surgery. Looking at salvage breast conservation, those numbers vary in the literature, but I think you can probably say between 15 to 30%, I would say, would be a second local regional recurrence after salvage breast conservation therapy. I do think mastectomy is still the standard of care, but in a certain subset of women, we should be able to consider this as an option. I think when to consider this: breast conservation and radiation therapy for primary breast cancer treatment. If there was, when you look at the group of breast conservation and radiation therapy, the preeminent study, I think, that originally kind of gave us some background to this was from our colleagues in Milan at the European Institute of Oncology. Gentilini and his colleagues, Veronesi, looked at really kind of two big groups of tumors. One was those that were less than 2 centimeters and recurrence rates over 48 months for time to relapse, and then the smaller tumors, again less than 2 centimeters, less than 48 months from time to relapse. And there was a difference in terms of the second local regional recurrence of 15 versus 31%. Who's not a candidate? I really think those that have genetic mutations, multicentric disease, really large tumors. These could be candidates for clinical trials. So looking at our European counterparts in Milan between 1997 and 2004, nearly 300 patients with operable invasive ipsilateral breast tumor recurrence after breast conservation with whole breast irradiation. 161 of these patients underwent a second breast conservation procedure. Median follow-up was 44 months. And the 5-year cumulative relapse rate was 31%, which is high. However, when you look at this for tumors that were less than 2 centimeters and the timing of the in-breast recurrence, if it was greater than 48 months, that number was much lower than if it was a really quick recurrence within the first 48 months after surgery. On multivariable analysis, what are some of the factors associated with local disease-free survival? One was the size of the tumor. Next, as we saw, was the timing of the ipsilateral recurrence. And that also was seen in the disease-free survival portion and overall survival portion. Looking at local disease-free survival, again, I think it's the size of the tumor and the timing. The 5-year cumulative incidence of a second recurrence was only 15%. If this was an extended period of time, again, greater than 48 months, as opposed to a quicker local recurrence of less than 48 months. The KLOR-RX group, led by Dr. Irene Wapner, on the poor prognosis after second local regional recurrences. Looking at this flow chart of their patients who underwent either, this is treatment of the primary breast cancer and the site of treatment of isolated local regional recurrence. If you look at those that underwent breast conserving therapy and those that underwent ipsilateral breast tumor recurrence, and then going on, most underwent salvage mastectomy, and a second local regional recurrence was only seen in 6 patients. They did have 16 patients that attempted repeat breast conservation, and those recurred in 2 of those patients. And when you go down the route of mastectomy, well, most were chest wall recurrences. Most underwent chest wall resections with the use of radiation therapy, and in 5 of those patients, there was a second isolated local regional recurrence. When you look at the factors associated with this adjuvant chemotherapy was the strongest factor that was seen. So how can we improve local recurrence after local recurrence and possibility of disease-free survival for those patients who undergo repeat breast conservation therapy? Certainly the role of radiation and the use of partial breast irradiation, and I really thank my colleagues, Dr. Alphonse Tagian at Mass General and Dr. Jennifer Bellin at the Dana-Farber for providing me the slides and the background for this. For accelerated partial breast irradiation, the ESTRO working group study has been underway, looking at 217 patients who underwent lumpectomy. This was a European multi-centric retrospective study. The median recurrence tumor size was 11 millimeters or 1.1 centimeters. The median time was actually relatively long. To recurrence was 9.4 years with a median follow-up of 3.9 years. The 5 and 10 year second local regional recurrence rates were actually relatively low, 5.6 and 7.2%. Really pretty robust overall survival, and the conclusion of this study suggested that in breast tumor recurrences with lumpectomy plus MCB is feasible and effective in preventing second local regional recurrence, and the overall survival rate was at least equivalent to those that achieved with salvage mastectomy. Methods of radiation, one is catheter-based or interstitial implant, low and high dose rates. Dr. Vicini has a very large experience on that. And the re-radiation, if it was going to be attempted in salvage breast conserving therapy, whole breast radiation is a standard for primary breast conservation. If they do not receive radiation therapy, in general, it is not recommended for repeat breast conservation with whole breast radiation. Current RT practices for salvage or repeat breast conservation therapy is really not well agreed upon, and you could either consider accelerated partial breast irradiation or interstitial brachy therapy. And these are probably fairly equivalent. Regardless of the technique used, limiting the field and the duration appears to be beneficial both for the toxicities of repeat radiation therapy and outcomes. There are intracavitary application methods outside with Mammocyte and many others out there, and those are being studied in multiple settings in the United States and around the world. Certainly we can consider electrons in those centers that have it, in patients that are undergoing repeat breast conservation therapy. Intraoperative radiotherapy, again, in those centers that have it, is something to consider. 3D conformal photons and mix. Again, a lot of this experience comes from our counterpart, Dr. Vicini at Michigan. I think the last portion, which really we won't have time to go through in great detail, is the axillary management after initial breast conservation. I think patients should undergo repeat axillary evaluation if there is concern for ipsilateral breast, if there is an ipsilateral breast tumor recurrence and there's no prior axillary lymph node dissection, you could consider repeat sentinel lymph node biopsy if they've undergone a repeat sentinel lymph node biopsy. I think the data supports the feasibility of this using dual tracer. And you should consider, if you have abnormal pathologic lymph nodes and that are biopsy proven, to consider actually really doing an axillary lymph node dissection. If they've had a prior axillary lymph node dissection, if clinically negative on examining no further therapy, repeat sentinel lymph node biopsy, the identification rates certainly are lower. There's aberrant mapping that we have to be concerned about, but it is something that can be considered in the appropriate setting. Certainly those that have had, for example, a sentinel lymph node biopsy after mastectomy, those identification rates are really low. So this is really a lot to cover. It's a very fascinating area with many areas of exciting research. I think putting all these pieces together is that post breast conservation therapy, one, recurrence rates are usually fairly low. If it's after breast conserving therapy, it's usually image detected. The timing of the recurrence is usually slightly later than mastectomy, which is found on clinical exam. Diagnosis and pretreatment evaluation. The diagnosis evaluation of a suspected local regional recurrence should include a full staging workup to exclude distant metastatic disease, which potentially would preclude local therapy. I definitely think biopsy is warranted to confirm that this is a disease recurrence. The expression of hormone receptors in HER2 may have changed. This could tell us whether this is a true local recurrence versus a second breast primary. This is from Dr. Cardoso in the Annals of Oncology, and I think it is very reasonable to look at local regional recurrence after breast conservation with radiation therapy, that the standard is mastectomy. However, considering breast conservation therapy in appropriate cases, after mastectomy without adjuvant radiation therapy is wide excision and local regional recurrence. After mastectomy and adjuvant radiation therapy, complete excision, and if you can appropriately re-irradiate, and then using this pseudo-adjuvant chemo and or endocrine and or targeted therapy. I hope that was clear. I know this is an interesting picture. This is Hong Kong from the Mongkok side looking at Kowloon. Again, I hope we can be together next year. I thank you for your attention. I really look forward to the discussion later this afternoon. Thank you so much. Take care.
Thank you very much, Professor Mehra, for your comprehensive presentation. Now, next speaker.
We are running out of time. Now we are going to move to our next speaker, Dr. Ahmed Magdy, Lecturer of Medical Oncology, National Cancer Institute, and Chief of Medical Oncology Department in Sheffield Orman Hospital. He will give us a nice presentation about, he didn't want to reveal the details.
Thank you so much for inviting me to this world-class event. Thank you, Professor Hisham. And actually, I need your insights in really this patient. This is a true case that I'm going to see next week in my clinic. So we have this gentle lady who is 59 years old with 4 offspring with no past medical history of any relevant importance to us. She had a right painless lump, which was hard. Again, painless, as usual. And then an ultrasound showed a 3.5 by 4.5 centimeter lower outer quadrant suspicious ill-defined mass. So with a BIRAT 4C, so it's a highly suspicious or most probably malignancy. Sorry, it's not. I'm sorry. So the biopsy actually showed invasive papillary carcinoma grade 3. And if you look at invasive papillary carcinoma, and this is why I'm getting this case. And actually this, I showed you a part of the pathology report which confirms that this is a papillary carcinoma. And we ruled out it's not coming from any other place, like thyroid, for example, or anywhere. And actually, the mitosis is really high with a grade 3. So if we look at the literature, papillary carcinoma itself as a papillary carcinoma or papillary breast lesions is 0.5% of all our breast lesions that we see. And more prevalent in elderly postmenopausal women. And if you look at our patient here, she is 59 years old. And actually, it has a favorable prognosis. And please concentrate on this part. This is why I told you, Professor, that please don't reveal what I'm going to say. And it's usually ER and PR positive, HER2 negative, and it's always like luminal A-like. For my patient, she is triple negative with a Ki-67 of 60%. So again, this shows you that this is really an interesting case. Metastatic workup was free, considering the CT chest, abdomen, and pelvis, bone scan, everything was free. And she was consulted in the MDT, and clinically she was T3 and was referred for neoadjuvant chemotherapy. So we gave her 1 cycle of doxorubicin cyclophosphamide, and after we saw her before the 2nd cycle, which is 21 days later, she progressed clinically in the form of T4, breast ulceration, and increase in the breast mass size. So we referred her back to surgery up front for modified radical mastectomy to try to save everything, and the pathology actually showed the mass has increased to 12 by 12 centimeter, with lymph nodes again 0/27, which is part of the papillary carcinoma. It is a localized, or the papillary breast lesions are mostly localized. So she is pathologically T4, N0, M0. So my question to storm our brains together, would you recommend revision of the hormonal profile on the pathology of the modified radical mastectomy? Keeping in mind, I didn't mention that the core biopsy at the beginning, we repeated the pathology, we repeated the hormonal profile just to make sure. My second question, any role for adjuvant chemotherapy, because clearly when we gave her the AC, which is considered a strong combination, did not do anything, hence she progressed. And I'm not a radiotherapist, but I'm asking my colleagues here, do you have any special radiotherapy techniques? And thank you for listening. No, I need your insights, please. Professor Heba, thank you.
Sensitivity, of course, yes, because this may represent some escape channel for the treatment of the patient, and maybe this is a focal papillary disease covering intraductal carcinoma or lobular carcinoma. This is our aim in this patient. So yes, we will. I highly recommend repetition of pathology as well as ER, PR, HER2, and KI as well.
Okay, the pathology of after modified radical mastectomy is again confirming
papillary.
Invasive papillary carcinoma grade 3.
Okay.
Again. But we did not repeat the
You have to.
hormonal profile.
Because she's young,
Okay.
and I will not jump to some conclusion, but because she's young and rare and not responding to anthracycline, you have to do some BRCA testing as well. Triple negative, huh?
Our international audience mentors, sorry?
What about TILs in the pathology?
Sorry?
TILs?
No, we didn't do that. No, we didn't look at that.
The pathology report, did it report any TILs?
TILs, you mean tumor infiltrating
Lymphocytes,
lymphocytes?
yes.
No, it wasn't reported in the pathology.
No, zero?
No,
Not reported?
not reported, sir, not reported. What about the chemotherapy? Because we gave the AC, and we all know the AC is really a strong combination. And then, would you recommend to give her an adjuvant chemotherapy, given that the AC, after 1 cycle, the patient clearly progressed to T4 with breast ulceration? Sorry? So what do you recommend here? So we would... Given the data that platinum salts should or have some effect in triple negative patients.
Even in triple negative, carboplatin it work.
Okay.
Papillary carcinoma or papillary invasive, we treat pathology, not treating a site of breast. So I believe in this protocol, carbotaxol would work.
Okay. Any other recommendations? Okay. For the radiotherapy, would you have, again, I'm a medical oncologist, so my knowledge about radiotherapy is nil. So would you recommend some sort of special techniques for radiotherapy or booster doses, given that this is an aggressive tumor, locally aggressive.
Dr. Ahmed, please, here.
I'm not.
Okay. You didn't receive, she didn't receive radiotherapy at all?
No, she's still, actually, I'm seeing the patient next week. She just finished her modified
Just